Welcome to the Go-To Physio Show. Coming up on today's show, we take you through a real life knee joint assessment that's going to make sense of the symptoms in front of you in real life. I'm also going to show you how to strap an MCL as if I would do it working with a professional athlete. I'm also going to share the one thing that you must not say to a patient if you want to have a successful business. I'm finally going to show you how to build your confidence and how to build your patient's confidence so that you can get that ideal outcome for your patient to help you become that go-to therapist. So welcome again to another episode of the Go-To Physio Show. Now we're going to start this week's show looking at the knee. Now rather than looking, and teaching to suck eggs, I just want to bring your awareness to some key points when you're actually doing your knee joint assessments, okay? And the big kind of thing that I want to focus on first is if there's a knee joint effusion in the actual knee, okay? Now, from clinical experience, the sweep test is very, very useful, okay? And whenever I've sent guys or girls for MRIs, especially in sport, that sweep test was a really, really good indicator of if there was an effusion in the knee joint itself, okay? So the sweep test, all we're going to do first and foremost is we're going to go down into this VMO, okay? So where the VMO attaches, and we're just going to sweep up, okay? So we're going to sweep up, and then I'm just going to come down the outside of the vastus lateralis, and I'm just going to rub that vastus lateralis, and I'm going to go down. And what you'll usually see is you'll see a pocket of fluid. So I'll get you a cutaway clip here of an actual positive, okay? One of my good friends and a physio actually had one of these, okay? So we'll get a clip of that, but you'll see a pocket of fluid usually emerge in kind of that space where that VMO attaches, okay? So that's going to be really, really useful for you in terms of a key performance indicator that I always talk about in terms of actually progressing your athlete. So that's going to be something that I personally take a very, very keen interest in. Now, if that's quite acute, I'm not a massive fan of letting athletes train with a knee joint effusion, okay? Yeah, there is research and literature out there looking at knee joint effusion and muscle inhibition, etc., but it just doesn't sit comfortable with me in terms of risk reward. And usually if it's acute and then the rest of these tests that I'm going to go through in a sec are negative, then usually these will settle down, quite quickly, okay? But if an athlete has a knee joint effusion and they're continuing to run it and that effusion's getting bigger and bigger, okay, then, that probably to me means that these tissues are continually to get irritated, that we're not finding the true cause, and that these tissues and the knee joint is continuing to get stressed, okay? So that sweep test is going to be a key performance indicator that I would encourage you to use session by session, okay? And ideally after kind of 2 to 3 sessions, we want this gone in the private practice, okay? So we want that knee joint effusion to have resolved itself, okay? If that knee joint effusion continues to hang around, okay, and it's an acute injury, and that's just making me think, okay, why is the nervous system, the brain, hanging on to this knee joint effusion? Why does it think that it needs to have this at the moment? Okay, what's it trying to protect? What's it trying to heal almost? Okay, so that's something to take into consideration. Now, in terms of meniscal tests, okay, I can say hand on heart that I have never, in 10 years of professional sport, had a positive McMurray's or a positive Aspley's. Okay, and that's what I meant in the first episode where I said the special tests, they're not really that special at all, and we know that they're not great. Some tests, some are a little bit better than others, so it's putting the whole picture into consideration with the mechanisms, with the injury history, with the person's story, and starting to make sense of that. But the one thing that I will say that I've found clinically to be very valuable is overpressure. Okay, very, very simple. So that knee joint extension, we know that's going to stress the anterior meniscus a little bit more. Okay, do they get a nip? Are they lacking knee joint extension? And then the big one for me that I use, okay, is a lot of overpressure. Okay, so again, I'll get this ankle joint and I really want to push that heel to the bum. So again, obviously we're going to stress more the posterior compartments of the meniscus at that point. So if that person has a knee joint effusion, they've got joint line tenderness, okay, and again that kind of pinch in the back of the knee with overpressure, then we're thinking, okay, maybe the meniscus is irritated, okay? Now the difference between a stable and non-stable meniscus, you'll probably be able to tell based on that person's function, okay? So my higher level knee joint exam, when I get them in standing again, that would probably give me more of an indication then whether this is stable or unstable, okay? And then another indication of whether this is stable, unstable, or problematic will be how quickly this knee joint effusion settles and how quickly that pinch in the back of the knee settles as well in the next session, okay? So it sounds obvious, but time is very, very useful as well to see how quickly it settles, okay? So that's the first big thing, is don't be afraid to use overpressure. Now, just because the patient has a pinch, they've got joint line tenderness, don't forget the majority of the tenderness that you're actually feeling, okay, is coming from the knee joint capsule, okay? The amount of receptors there, okay, that combined with the effusion or some whatever is in there, okay, that's probably the majority of what you're actually feeling. That meniscus doesn't have any receptors, okay? So again, it's going to usually be the capsule and the actual the effusion that's going to contribute to that pain experience more so than the actual directly that meniscus, okay? So obviously, yeah, the meniscus having some trauma is probably going to cause the effusion, cause the capsule maybe to react a little bit, and then clinically when you're touching that capsule, you're eliciting that pain experience, okay? So just keep that in mind. So then if we can desensitize this knee capsule, okay, then very often we can take away a lot of these kind of pinches and stuff like that. We take away that pinch, we maybe just want to keep that range, we want to find, then that's my 20% done on the knee joint. My 80% then is focused on what's causing this knee to overload in the first place if there wasn't a mechanism, okay? They come in the next session and then we're looking at our key performance indicators. In this scenario will be my knee joint effusion, overpressure, okay? Have I kept the gains that the person left with, okay? If we've kept them, great. It means the loading that we're doing now is appropriate. It hasn't caused a negative reaction. If they come in the next day, they're worse, okay? The knee joint effusion is huge. I'm like, okay, first thing I'm doing is, okay, tell me about your week. What did you do? I want to question them a little bit more. Maybe they've gone, you know what, I felt great, so I said I'm going to have a run, okay? Again, because we've only taken that 80% true cause through a small level of loading, that person wasn't ready to run. That's my fault. I didn't have effective explanation in telling that person the plan for the next few sessions. Okay, so I need to take responsibility with that just as much as the patient does. Okay, we need to look at ourselves as well. Okay, so that overpressure, it's a very, very useful test. Okay, it's obviously going to stress a lot of tissues, you know, along the surface of the patella, and obviously along the joint line as well a little bit, okay? So really, really useful test over pressure to get these meniscus. But again, combining that joint line tenderness and knee joint effusion, the three of these clinically for me have been absolutely vital over the years, okay? So the next test that I want to talk a little bit about is the actual MCL, okay? So when you're stressing the MCL, you want to have intent with what you're actually trying to do. So I see a lot of new grads and I see a lot of students, etc., when they're actually stressing the MCL, and if we do it from this side, okay, when they're actually stressing that MCL, okay, is they'll just go through the motion. So what you want to be doing is you want to find the joint line and you're trying to gap that joint line on the inside. So as I push, my intent wants to be pushing in that direction through that medial joint line. I want to gap that medial joint line, okay, and I want to see if there's any pain response, okay, if there's an end feel. If you do this and it gaps massively, don't worry about it, okay. One of the world's best number 10s rugby union player that I've worked with, when we done this MCL with him, I was assessing him, it kept going. And he said to me, don't worry, I've done my MCL a few years ago, okay. So again, a lot of these people, they may have done these MCLs in the past, and from my experience, they don't knit down very well. Okay, so when I was in Australia this year, we did an MCL, or last year for the Rugby League World Cup. Went to a surgeon in Melbourne, and he was saying, look, the knee joint, the biggest thing with the MCL is that it's stable in extension. Okay, so again, with that knee extended, and we're going to gap that knee, we've got that solid end feel, brilliant. Okay, you can obviously do it with more of a bent knee, but then it's a little bit harder to get that true valgus stress as well. Okay, so that's a big one, is joint line pressure as opposed to just going through. Okay, so again, if my hand's here and I'm pushing with my fingers here, I'm probably pushing that way. So I want to have my thumb, my hook hammer, whatever you want to use, and that's direct pressure through that joint line. It's the same with the MCL. I'll usually come in here, and then I'm right on that joint line, and I'm almost pushing that way to gap. And again, I want to feel that end feel. You can see Pete there. Okay, so if I do it dynamically, that force is going pretty much in the frontal plane, whereas when I get into knee flexion now, it's just getting a little bit harder. I can still gap it, but there will be a little bit of rotation, okay, in the transverse plane the second I flex Pete's knee. Okay, you can still do it, but just keep that in mind as well. So definitely want to check it extended, a little bit flexed. Okay, with the MCL, one of the key performance indicators for me with an MCL is full knee flexion pain free. Okay, so with a lot of these MCLs, you can have a patient and they're just getting a little bit of a nip in knee flexion, especially if you decide to brace them. Obviously that knee is going to get a little bit stiff once you get that flexion back. I love, okay, and for me it's one of my KPIs that they have to have that full knee flexion before we start running, okay, because you might get away with low level jogging at the moment, but you'll get found out when you ask that athlete to go above 80% usually. So as they start to sprint and they open it up, they'll be almost dragging the leg rather than letting that heel come right up to the bum as they sprint. Okay, so I like that full knee flexion to be restored. And again, it makes sense. If there's trauma to the MCL, there's going to be probably trauma to the knee capsule as well. That knee capsule is going to tighten as we flex the knee. That capsule has to lengthen. Okay, so it's pretty important to desensitize too. For the ACL, I like the Lachman's test. Okay, so again, if you are doing your anterior draw, the one thing I would say is just try take up the tendons. Okay, so again, when you compress and load that tendon, that's going to help the hamstrings, the gastrocs to relax a little bit. Okay, and you can do your draw. Okay, you can do your posterior draw. I had a guy the other day that I was suspecting, and again, I want to give it a good bit of force, because again, I would rather be a bit aggressive here and just irritate him a little bit rather than not be aggressive enough and miss it. Okay, but for me, for an ACL, I like a Lachman's test. Okay, so all I'm going to do here is I'm going to keep the knee like this. I'll put my hand on the quad. I'm going to take up the slack through the tendons again, and again I'm just going to pull up, and what I want to feel is a good end feel. So I'm taking up the slack in the tissue and my force is going straight up. Okay, in one single movement, and am I blocked with a good end feel? Okay, if we get that good end feel, I'm very, very confident. If you have one of these straight out after a game and they've just come in from the dressing room or from the field, okay, don't worry if you can't really feel an end feel. Again, the hamstrings go into quite a bit of protective tone, etc. Okay, so it's one that it can give you a false positive very easily. But again, the next day, effusions, knee joint effusions, that's going to give you a clue, although I've seen ACLs as well with very, very minimal knee joint effusions. Okay, so again, if it's just the ACL, there's no meniscal damage, etc., sometimes they don't swell up. Okay, so that are the big ones. I'm trying to think: ACL, MCL, LCL, PCL, the meniscus. They're the big ones that we'd want to check. From a more of a knee joint assessment, from non kind of traumatic knee joint, you want to consider the difference in knee joint range of motion, prone to supine. So again, when we look at knee joint flexion, okay, the distal tissues are going to lengthen more, while the proximal tissues aren't required to lengthen. Whereas when the athlete's on his front and we get his knee to his bum, then all the tissue, distal and proximal, are going to lengthen. Okay, so again, I'll give you a clue there. Start clinically reasoning the difference in tissues that are required to lengthen and maybe it may be more appropriate then to focus your attention on the tissues that need to lengthen in those specific scenarios. So again, that's just your 20%. We still want to find out through our assessment the key 80% of what's not doing its job to cause this quad or this knee joint to take excessive load. Okay, so 80% of my attention then is going on that, and that's what I would have found out with my assessment. Okay, so as I said, what I've just shown you today, that's finding the 20% that we're going to respect, we're going to desensitize, but the big thing that we've left as we go through our assessment, which is a whole body assessment, is what caused this to take excessive load in the first place. Okay, so any questions, any comments, post them in the comments of our YouTube page, or you can put them on our Facebook page, and more than happy to get back to you. Okay, so we're just going to do a MCL strapping. Now, I'm not one of these therapists who gets terribly obsessed over my strapping, but it's still good to be able to execute it efficiently and it look okay, so that it doesn't throw the patient or knock their confidence, which some athletes can get a little bit. So I like to have an odd end just to get a little bit of knee flexion in the knee when I do this. Okay, so what I'll do is I'll usually get tear light. A bit lighter than this. This is the AAB version, but you can get the kind of the tear light version as well. Okay, so some physios struggle to tear this with their hands. Okay, but touch wood, I'll be able to do it myself. Okay, so you can get an anchor here. As I said, you can have the lighter tape if you want. So just an anchor usually around here. Okay, and then we're just going to tape that there. Okay, so then the key thing here is we just want to go across the joint line. So find the joint line, okay, and I just want to crisscross around that a few times. Now, I'll usually just do a zinc oxide marker, or anchor I should say, here. Okay, so I'll pop one there, I'll pop one here quickly. Okay, then I'm just going to start here, and I'm just going to cover that joint line basically. Okay, so I'm going to go to here, and then I'm going to cover it again. Again, I'm just trying to hit that joint line. So it's going to end up there, and then I'll usually put one down the center of it as well. Okay, so I'll hit it here, and that's what you'll look like there. Okay, then you're just going to repeat that. Okay, I'll usually do it twice. Some athletes, they'll get a little bit funny in their head. Oh, just do one more, a little bit here, a little bit there. So on game day, don't argue them too much. One day of the week I don't. And we'll do that, okay, and I'll close it off then. Okay, so I just want to close that off like that. I'm going to close it there. Okay, and then I'm just going to go over that then with the either this, or you can go with the so this is 7.5 centimeter. You can go over it with 5 centimeter if you want. It just depends on the athlete. So we're just going to go here again. You can help guide the tape. Okay, then usually I'll close it here, and then I'm just going to finish up around here usually. Okay, you can get away with just doing one there. Some athletes, they may like to do a few times. Okay, so again, that's just completely up to the athlete, and then I'll usually just close it off with that, and then usually that'll be pretty good for them. And then you take your foot off, and then they're pretty happy with that. They've got a little bit of bend in it. And they can obviously straighten it as well. Okay, so the contours with that little bit of bend, it tends not to crease. Okay, so that's my MCL. Nothing special. As I said, it's pretty straightforward. The key thing is you just hit the joint line, hit your anchors, and then you can use different tear light as well instead of the AAB. The Therapist Mentorship Program was put together to help you accelerate your ability to have confidence and clarity with any patient that comes through the door. It's a very intimate 90-day experience where you work closely with myself and my most trusted therapists to put together a very, very specific structure in your assessment, your treatment and your rehab for every single patient, so that you can truly get the results that both you and your patient deserve, so you can become that go-to therapist. If you want more information, just click on the button below this video or go to thegotophysio.com/mentorship. So welcome to this week's Build Your Business segment. Now this tip is going to save you thousands upon thousands of pounds if you listen to what I'm saying, or thousands of euros or dollars, whatever country you're listening to this in. And that is, never ever say, give me a ring and let me know how it's going. Okay? Never ever say that to a patient. Okay? Because 9 patients out of 10, life is going to get in a way. Now, leaving your clinic on that day, that person has every intention of giving you a ring the next week. The problem is they have kids, they've got work going on, all sorts of stuff. Life gets in the way. Oh, I'll ring them next week. And before you know it, it's 2 months and you're like, oh, that patient must be fine. The problem is, a lot of patients, they'll still have the same pain. Okay, I'll ring them next week. I'll ring them next week. Okay, now in the next few episodes, I'm going to give you strategies, okay, to make sure that these patients, if you have said that to them in the past, will actually go back and ring you. But that is the most important thing that you do not say to a patient. Because what I found with a lot of therapists is they'll actually go to the patient, I need to see you, and then they're looking for clues in the patient's face of their and a reaction. So I might need to see you next week. And then they perceive the patient's gone like that, okay, or they made some facial expression and go, actually, you know what, I'll see you in 2 weeks. Actually, you know what, just give me a ring in 2 weeks when and let me know how it gets on, because all of a sudden you're on holiday that week. Okay, and then all of a sudden that patient who you actually genuinely needed to see next week, they've gone out of your care. And then that's a patient that instead of you discharging, they've self-discharged pretty much. Okay, that patient, the chances of them giving you a good word of mouth referral, it's pretty much slim to none if they're still walking around with the same complaint that they came into you with. Okay, so you have to be really disciplined and never ever saying, sure, give me a ring and see how it goes. Just because you didn't have the discipline to book that patient in. Just because you're away on holiday in 2 weeks, you've got a little bit slack the week before. Okay, and it happens to all of us, and it's happened to me in the past as well. But though it definitely does not happen here in the clinic now as we've started to grow the clinic. Okay, so that's your business tip. It's going to save you thousands. Okay, and just bring your awareness to it. If you need to see the patient next week, you need to tell them and you need to give them a reason why. Okay, don't be looking for facial expressions, and 9 times out of 10 you're perceiving the wrong thing. They might just have a twitch in their face, okay? But yeah, so make sure you never ever say that, okay? And it'll save you thousands. Bring your awareness to it this week. Let me know in the comments if you've been guilty of it in the past. Let me know what you did say this week instead of saying that.
So my name's Maria, I am a physio and I'm currently working in Galway. For the mentorship, I suppose, was just kind of the final stage rehab of people, so like the return to play, full return to function. I actually came across it on Facebook and it looked really good. Once I had a chat with Dave and he talked me through what it was involved, it just sounded like right up my street, and the whole starting from the very scratch and bringing people right through. I suppose it just gave me the focus in terms of the hands-on treatment, and then really focusing and being precise with that, and really knowing how to progress people. I suppose just how simple things can be, you know, like I think we do overthink it a lot, and if you just take a step back, have another look at it and really simplify it, it just makes results a lot quicker and makes my life a lot easier. It's helped me in terms of my confidence with people and, you know, progressing them through the stages, helping them, you know, realise their capabilities, and then taking that, you know, maybe fear avoidance patterns that people would have had away. Do it. Yeah.
Welcome back to another episode of the Brain Booster. Delighted to have Carl Morris here virtually with me for this episode. Carl, thanks again for joining us. I've had great feedback from therapists
all over the world in implementing your stuff, which is why I like it, because you can apply it in the real world. It's a bit of a lost art sometimes with that stuff.
Good to hear, Dave, and good to be back with you again.
Great stuff. So I've just had a question from a therapist in Australia, and he's just asked, how, Carol, do you deal with an athlete who's had multiple setbacks with a hamstring injury? How could we approach this as therapists, or is there anything practically that we could do to implement in the real world?
I think one of the things that this ties in with, Dave, is something that we've talked a lot about over the years, and that's the power of the story. That we build a narrative about things that happen to us in our life, and if we repeat the story enough times, it becomes a very, very strong belief. So, although an athlete may have had, numerous injuries, it's actually the power of the story that we need to look at, because if they create an identity that they are the person who has this kind of injury, we can kind of get nowhere. And for me, one of the most important things that you can do to change the story is to shrink the time frame. If you think about, if somebody's had numerous injuries, they've got a past history of that. And the danger is then looking too far ahead of what may or may not happen to them in the future with their career. One of the best ways to deal with that is, we've talked a lot about it, is accumulating good days. What can I actually do today? Because there's always something that I can actually do today to move forward from where I am, be that with an injury, be that within developing your skills or whatever. And I think what tends to happen is when we get too involved in the story of what may or may not happen in the future, we end up thinking and not doing. So it really is important that we shrink it and, ask the question, what does a good day look like today? Because when you've done something in that day, you actually get a sense of achievement. So that what you're not doing is being what I call bound up by the story, bound up, as I said, by the past, bound up by what may happen in the future. We're just really focused on, okay, what does a good day look like today? And you take action, because that's the key thing that makes us feel better. Now, that action, if somebody's in the early stages of recovery, might be some visualization that we can touch on at another time. But there is a fundamental thing, Dave, is that there is always something that you can do rather than sitting, thinking and drowning in thought.
That's brilliant, Karen. So that ties in with the last few episodes, and right. How we're going to do that is we're going to help that patient direct their attention to things that are useful and not useless. And I've robbed that from yourself, that phrase, and I use that with my patients all the time. So directing their attention to things that's going to make up the good days, which we're going to talk about in the next episode.
Just on that point, Dave, I think for everybody, probably the most fundamentally important question in terms of the mental game, whether that be the mental game of recovery or the mental game of performance or whatever, is what's my attention on? Now, just by asking yourself that question, what's my attention on, you get a choice. You get a choice of where to put it. And as you've said, the key principle is either you've got your attention on something useful or something that's useless. The problem is, when we think habitually. We get drawn into the story and we just keep these reoccurring thoughts going. Just by asking that question, what's my attention on, as I said, puts us at a choice point, and we can then move in a different direction. And that's basically what a good coach does. A good coach directs somebody's attention into a useful place. But often when you're an athlete and you're recovering yourself, you've actually got to do that job for yourself, haven't you? Because you're spending a lot of time away, maybe from the team environment or the coaching environment.
That's absolute gold, Carol. Thank you very much. And I can't wait to take this discussion up in the next episode.